Hi everybody, welcome back. Today we are going to be talking about the hypothalamus. If you have not already watched the Endocrine 1 and 2 videos, please go back and do so before attempting this video. For most homeostatic feedback loops in your body, the hypothalamus is the control center. This is the area that controls the set point for many systems. Remember from brain anatomy that the hypothalamus is located anterior and inferior to the thalamus. It is connected to the pituitary gland by a little stalk called the infundibulum. The hypothalamus controls important autonomic nervous functions, such as setting the set point for body temperature and regulating sleep-wake cycles or circadian rhythms. It also monitors water balance and determines when you are hungry and thirsty. The hypothalamus is also important in controlling lots of different endocrine functions, such as growth, metabolic rate, stress responses, and reproduction. The endocrine functions of the hypothalamus involve the pituitary gland, which sits below the hypothalamus in an area called the hypophyseal fossa that's in the sella turcica. They're connected by a hollow stalk called the infundibulum. There are two lobes to the pituitary gland. The posterior pituitary is called the neurohypophysis. It is made out of neural tissue, and although it secretes two hormones, those hormones are actually made by the hypothalamus. The posterior pituitary only stores them until they need to be released. Taking a closer look, you can see that the neurons in this nervous tissue have their cell bodies in the hypothalamus and their axon terminals in the posterior pituitary. The two hormones that are associated with the posterior pituitary are therefore made in the hypothalamus, travel down through the axons inside the infundibulum into the posterior pituitary, where they are stored until they're needed. Therefore, the posterior pituitary is not a true gland. It does not make the hormones itself, which is why we call it a neurohypophysis. The other lobe of the pituitary gland is the anterior pituitary, and it is true glandular tissue. We call it the adenohypophysis, as adeno means pertaining to the glands. Taking a closer look, you can see that the anterior pituitary is connected to the hypothalamus by a tiny blood supply called the hypophyseal portal veins. A portal vein is a blood supply between two capillary veins. This hypophyseal portal vein goes straight to the anterior pituitary and causes it to make and secrete one of the 6 hormones into the hypophyseal vein. From there, it enters the main circulatory system. In this way, both the hypothalamus and the anterior pituitary are acting like endocrine glands, making and releasing hormones directly into the blood. Regulation of this system is important. Think of the hypothalamus as the control center. It makes a releasing hormone and secretes it into the hypophyseal portal vein. These are called trophic hormones, as the target is another endocrine gland. The target here is the anterior pituitary. The anterior pituitary makes a hormone in response to the releasing hormone. It's usually called a stimulating hormone. And that hormone is a trophic hormone also, meaning its target is also an endocrine organ. Those 6 stimulating hormones are released into the hypophyseal vein and are circulated in the bloodstream to act on another peripheral gland somewhere else in the body. You can see the 6 targets are bone, muscle, the thyroid gland, the adrenal glands, mammary glands, and the sex organs. This is a classic negative feedback loop, although with more levels than what we are used to. You can see here that releasing hormone acts on the anterior pituitary. The stimulating hormone from the anterior pituitary not only activates the peripheral endocrine gland, it also inhibits production of the releasing hormone. And the end product hormone not only acts on its target cells, it also inhibits both the hypothalamus and the anterior pituitary from continuing to produce more releasing and stimulating hormones. To keep things straight, let's match up the hormones and see how the hypothalamus makes the releasing hormone and the anterior pituitary will respond to that specific hormone with the stimulating hormone. Growth hormone, releasing hormone, is produced by the hypothalamus, and it stimulates the anterior pituitary to produce growth hormone. This is going to stimulate mitosis in its targets. Thyrotropin-releasing hormone made by the hypothalamus is going to stimulate thyroid-stimulating hormone from the anterior pituitary. This will target the thyroid gland, which will cause the release of thyroid hormone. Corticotropin-releasing hormone made by the hypothalamus will stimulate the release of adrenocorticotropic hormone from the anterior pituitary. This is going to target the adrenal cortex, causing the release of hormones, mostly cortisol. Gonadotropin-releasing hormones from the hypothalamus will act on the anterior pituitary and will stimulate the release of either follicle-stimulating hormone or luteinizing hormones, which act on the sex organs, stimulating further secretion of sex hormones. And there seems to be a releasing hormone from the hypothalamus that stimulates the release of prolactin from the anterior pituitary. However, we're not sure exactly what that hormone is. Prolactin targets the mammary glands and stimulates production of milk. There are also two inhibiting hormones made by the hypothalamus: growth hormone inhibiting hormone and prolactin inhibiting hormone. These both inhibit release of the corresponding hormones from the anterior pituitary. The negative feedback loop that controls most of the release of these hormones starts with chemoreceptors in the hypothalamus monitoring blood for the end products. Let's get more specific about each of these hormones. Thyroid-stimulating hormone is made in response to thyrotropin-releasing hormone. This hormone stimulates the thyroid gland to produce thyroxine and tetridothyronine, T3 and T4. These hormones increase the metabolic rate of the body. They increase growth and protein synthesis, and they help to increase the number of adrenergic receptors on body cells. Adrenergic receptors are the postganglionic receptors that respond to epinephrine and norepinephrine on the target organs in the sympathetic nervous system. Thyrotropin-releasing hormone and thyroid-stimulating hormone are triggered when T3 and T4 are low, during times of physical stress, and any time increased metabolism is required, like during a sympathetic nervous system response. The production of thyroid hormone requires iodine, an essential nutrient that we must get from our diet. We cannot produce it on our own. When we do not have access to iodine, thyroid hormone is low. Thyrotropin-releasing hormone and thyroid-stimulating hormone are triggered because of the low levels of that thyroid hormone. And although properly stimulated, the thyroid gland cannot produce enough thyroid hormone because of the lack of iodine. This can result in the formation of a goiter, a swelling of the thyroid gland as it struggles to vainly obey directions from the hypothalamus and anterior pituitary gland. In modern times, we have added iodine to salt, so we do not see much of this in wealthy first world countries. There are a couple of different autoimmune diseases that result from either too much or too little thyroid hormone being released. In Graves' disease, antibodies mimic the action of thyroid-stimulating hormone. Those antibodies force the thyroid gland to oversecrete thyroid hormone. Patients suffering from this affliction often are thin, irritable, have trouble sleeping, and are characterized by exophthalmos, which is eye bulging. The opposite situation can be seen in Hashimoto's thyroiditis. This is when the antibodies actually destroy the thyroid tissue, and the thyroid cannot produce enough thyroid hormone, resulting in hyposecretion of thyroid hormone. This is fairly common in middle-aged women. It is characterized by sluggish metabolism, weight gain, and lack of energy. Human growth hormone, or somatotropin, is produced in response to growth hormone-releasing hormone from the hypothalamus. This targets the liver, skeletal muscle, bone, and cartilage throughout the body, causing it to produce and secrete insulin-like growth factors. Insulin-like growth factors have a local effect, so they can be classified as paracrine or autocrine type hormones. In children, insulin-like growth factors cause growth. In adults, insulin-like growth factors help in muscle and tissue repair and in maintaining bone density. Secretion is stimulated by low blood glucose levels and deep sleep. Hypersecretion of human growth hormone causes giantism in kids, where everything is bigger. In adults, it causes a condition known as acromegaly, where the hands and feet and face continue to grow out of proportion with the rest of the body. Human growth hormone results in the increase of glucose levels in the blood. Hypersecretion or abuse of human growth hormone can cause diabetes mellitus. Adrenocorticotropic hormone release is stimulated by corticotropin-releasing hormone from the hypothalamus. It stimulates the adrenal cortex cells to produce corticosteroids, mainly cortisol. The amount of ACTH released is highest in the morning, falls off during the day, and is lowest in the middle of the night. Cortisol is anti-inflammatory. You may have heard of synthetic hormones that mimic the effects of cortisol, for example, prednisone or dexamethasone. Cortisol is produced in times of stress. It downregulates the immune system and mobilizes the body's resources for a sympathetic response, making glucose available as fuel. This is an excellent system to have in place when a bear is chasing you. It gives you ample fuel for extreme exertion and reduces pain and inflammation until after the bear has gone. However, in modern times, it may be more common to experience long-term emotional stress than immediate physical stress. In these cases, this is a terrible way for the body to respond because it reduces your protective immune system function and increases the generation and release of glucose. This is why emotional stress makes you more prone to weight gain and illness, and why asthma attacks are often worse at night, because the immune system is not controlled as well when cortisol levels fall. Adrenocorticotropic hormone can be hyper or hypo secreted. Overproduction or long-term overuse of cortisol or other anti-inflammatory steroids can result in something called Cushing's syndrome. You can see to the right the classic characteristics of Cushing's syndrome: fat accumulation on the back and face, abdominal obesity, high blood pressure, fragile, reddened skin, and sweating. Not having enough cortisol can lead to Addison's disease. This is usually autoimmune related. The characteristics of Addison's disease are darkening of the skin, abdominal pain, weight loss, and weakness. Follicle-stimulating hormone and luteinizing hormone are both produced in response to gonadotropin-releasing hormone from the hypothalamus. Follicle-stimulating hormone has similar activity, but different target organs in males and females. In females, it stimulates the maturation of an egg and stimulates the follicles to produce estrogen. In males, it stimulates production of sperm. Luteinizing hormone in females triggers ovulation of the mature egg from the follicle and stimulates the production of the corpus luteum. In males, it stimulates production of testosterone by the testes. The sixth hormone from the anterior pituitary is prolactin. We have not identified the releasing hormone for prolactin from the hypothalamus yet. In fact, what we have identified is a prolactin inhibiting hormone. This hormone stimulates mammary gland growth and milk production. Remember that the posterior pituitary is the neurohypophysis. The two hormones associated with the posterior pituitary are produced in the hypothalamus, travel through the neurons into the posterior pituitary, where they are stored until the hypothalamus calls for their release. The first hormone is oxytocin. This hormone is stimulated by the increasing pressure on the cervix leading up to childbirth. During labor, oxytocin causes uterine contractions. Remember that this is one of our classic positive feedback mechanisms in the body. The more uterine contractions, the greater the pressure on the cervix, and the more oxytocin is released. This cycle continues until eventually the contractions are large enough and strong enough to push the baby out. After delivery, the same loop happens during nursing. Stimulation of the nipple by a suckling baby will cause the release of oxytocin, which allows the letdown of milk. In this way, there are two hormones responsible for nursing. Prolactin causes the production of milk, which gets made and stored in the mammary glands. But oxytocin is necessary for the letdown reflex. Recent studies shows that this hormone is also important in establishing nurturing bonds and in regulating emotional and sexual pleasure in both males and females. Antidiuretic hormone is the other posterior pituitary hormone. Blood pressure and blood tonicity are monitored by the hypothalamus. When the blood pressure falls, or the concentration of solute gets too high, it stimulates the release of antidiuretic hormone from the posterior pituitary. ADH triggers several mechanisms to conserve water, which will decrease hypertonicity and raise blood pressure. First, it targets the kidneys to save water and reduce urine output. Second, ADH reduces sweat gland activity. And third, it increases vasoconstriction of arterioles throughout the body, which helps to raise blood pressure. If you remember back to the last video, we talked about aldosterone. Aldosterone and ADH often work together to increase blood pressure and retain water. However, remember that aldosterone triggers the active transport of sodium from the kidney tubule back into the bloodstream. Water follows the movement of sodium molecules back into the bloodstream. Antidiuretic hormone works in a different manner. It causes the insertion of aquaporins into the collecting ducts. This moves water out of the collecting duct into the bloodstream, but doesn't affect the sodium levels. This is a more direct way to control how much water is retained. Alcohol inhibits the release of antidiuretic hormone. Without antidiuretic hormone, urine output remains high and results in further dehydration after consuming alcohol. A more permanent problem is when there is damage to either the hypothalamus or the posterior pituitary gland, or if the kidneys are unable to respond to antidiuretic hormone in some way. In this case, the body cannot retain enough water. This causes something called diabetes insipidus. This is not related to glucose metabolism. In this case, there is excessive urination, but the urine is normal, meaning there's not too much glucose in the urine. This results in thirst, dehydration, and hypokalemia. The only treatment available is to drink more water to compensate. That's it for today. See you in class.